Good evening, everybody. This is Dave Cameron, and I will be presenting on skull fractures this evening. This is an interesting topic to me, having seen many of these myself, and I find skull fractures to be pretty fascinating. It's amazing the trauma that a human body can absorb and still survive. Um, I'll briefly share just a quick story. I remember one of the first uh, self inflicted gunshot wounds to the head that I ever saw. There was gray matter, there was bone fragments sticking out of this person's head, and they were still breathing. And it got my brain churning as a new EMT to think about how is this possible. And so learned quite a bit over the years as I've witnessed a lot of those, unfortunately. But there are many types of skull fractures. Much like any other injury, they can vary widely in degree of their morbidity and mortality. This presentation is not meant to be all inclusive, but rather to illustrate a few of the more common or at least noteworthy injuries that we may come across as nurses. There are simple fractures, and then there are very, very complicated fractures uh, with any bone structure, but especially with the skull. Head trauma in children alone accounts for more than 600,000 ER visits annually, and I always love the wide percentages that you find. But between 4 and 30% of these cases identify skull fracture as part of the patient's injuries. So there is a very high likelihood that as we go through our journey as nurses, that many of us will probably be caring for patients who have skull fractures. So the different types of fractures that I'm going to cover in this presentation include the Lefort fractures, type 1, 2, and 3, basilar skull fractures, depressed fractures, and comminuted fractures. So the Lefort fractures are classified as types 1, 2, and 3. Type 1 basically takes the maxilla and is a complete fracture of the maxilla. Type 2 goes from the bridge of the nose down through the maxilla. And type 3 actually is described as complete detachment of the face from the skull. Um, so they're pretty substantial, the amount of force um, that it requires to produce those types of fractures, and we're going to talk a little more about that. The second type, or the second class, is a basilar skull fracture, um, and this is a very commonly taught type of skull fracture, especially in the EMS world, where you guys are all bored of hearing where I come from. But basilar skull fractures have some pretty classic signs. Makes it easy pickings for testing, and so I think it's a relevant injury pattern to review in this presentation. Also, a depressed fracture, and I chose that one among the various because it's a fairly simple fracture. If you think about it, it's really just exactly what it sounds like. Um, it's just a depression in the skull. So we'll talk a little more about that as well. But the comminuted fracture is potentially one of the most catastrophic, or it can be. This CT image here shows some comminuted fracture of the frontal sinus and whatnot, and it could be relatively simple. Not that that's a simple fracture, but that's fairly simple. I've got some images in this presentation that demonstrate some pretty catastrophic comminuted fractures. So going through the Lefort fractures, Lefort was named for a French surgeon, and in 1901 and 1902, he performed experiments on cadavers where he produced controlled trauma on their skulls. And I can just imagine this French scientist in the early 1900s with a hammer or a rock or whatever he used, whacking these cadavers in the face and producing these fractures, and being able to discover the patterns that the facial bones would fracture in. And so if you look at the largest image here that's towards the back, right across the maxilla and under the nasal bones, you'll see that fracture line all the way across. So that is a Lefort 1. A Lefort 2 is the image that's to the right of your screen. If you ignore the arrows at the top that are clearly going across the, what would be the forehead, but if you focus on these ones here, that's the Lefort 2. And then if you look down in this image at the bottom, and in case you're wondering, that hose looking thing coming out of that mouth is actually an ET tube. And so either that or it's an OG tube, but pretty sure it's an ET tube. Anyways, but if you look, you can see across the nasal bridge and inferior to that is basically detached from the rest of the skull, and so you're able to actually visualize the Lefort 3 there as well. I found these images very interesting. The top illustration, if you look, there's little arrows that demonstrate how to move as the provider examining a patient who you suspect a Lefort fracture from. I thought that simple image with those little arrows to illustrate how to do that was a great illustration and very educational. And then down at the bottom, just a real live image of a Lefort 1 repair. And you can see the gold colored brackets bracing that person's maxilla back up to their their face. So pretty awesome demonstration of those injuries. The next class we're going to talk about is the basilar skull fracture. So again, people, I think, just often think that the head is the skull. They think of the whole head. People don't always realize that there is the face and then the head, the skull. The whole thing is the head, right? But the skull, which houses your brain, inside that cranial vault, is the most vital. You see this in gunshot injuries more often than you'd believe, where people will shoot themselves underneath thinking that they're going to kill themselves, when in fact the bullet or the shot from the shotgun will actually bounce off the bottom, the basilar part of their skull, and the back pressure will blow their face off, but it won't even get inside their vault and damage their brain. That happens actually a lot, and all manner of weapons. It's crazy how often that happens. So anyways, the basilar skull fracture, if you look at this image, you can see the illustration on the right there of the base of the skull fracture. And if a person has sustained a hard enough impact to their head in a way that they're able to fracture that, and they're leaking cerebrospinal fluid down into their face, and it's going into their sinuses, it's going to leak out of either their ears or their nose, and this is where we're going to find it as providers. It would require a fairly significant amount of force or just the right angle of force to transfer that energy and actually fracture the base of that skull from side to side. And this image in the lower right hand corner of this slide demonstrates some of the different angles and the anterior transverse, lateral frontal diagonal, posterior transverse, and the mastoid diagonal, just as routes that energy could travel to actually fracture the basilar skull. I think, as I said, one of the first and most traumatic injuries that gets taught to EMTs is the basilar skull fracture. And I think that's because it's relatively easy to diagnose based on this mastoidal ecchymosis, known as battle sign, which is this bruise behind this person's ear, and then what they refer to as raccoon eyes, or periorbital ecchymosis, seen here in this person's eyes. It's basically bilateral black eyes. Um, as nurses, if we have a patient that's been in the ER or maybe in the ICU, most likely the ER, um, that has been laying there for a little while, maybe they're 30 minutes or an hour post car crash or fight or whatever it is, and they begin to leak a serosanguinous looking blood down onto the bed sheet. You might notice this halo sign, which is illustrated here on a gauze patch. Um, but this is what it looks like. The blood will stay in the center, and the thinner CSF will actually move out, radiating out from that, and it creates what they refer to as a halo sign. So that's a pretty good indication that you've got CSF mixed with blood, and that your patient has a basilar skull fracture. Um, Moving on to a depressed skull fracture, it's just exactly what it sounds like. Um, there's a depression in their skull. Depending on the location of the fracture, the size, or the mechanism of the injury, this patient could be pretty darn stable, or they could have a GCS of 3 and be intubated and require surgery. Um, I looked at this image and it made me think: did this person trip and fall? Were they in a vehicle accident, maybe an older vehicle or a malfunctioning airbag, and hit their head on a dashboard or a steering wheel? Were they in a fight? You can almost imagine the edge of a bottle or a hammer or a stick, or you know some big giant fist punching this person right in their forehead, right across the bridge of their nose, and actually depressing their skull. So um, it's interesting to look at some of these images that don't have any explanation to them other than just what they are, and wonder about the history of how that happened. So another bit of information I found here is a simple depressed skull fracture includes an intact galea, and is usually treated surgically only if the depression is equal to or exceeds the thickness of the adjacent intact bone. So it's got to be a pretty decent depression. Or if there is an intracranial hematoma producing mass effect, or uh, altered mental status, signs of a pretty severe concussion, that must be removed in order to reduce potential or actual morbidity and mortality to the patient. So comminuted skull fracture. Again, I've got that image in the top left of that Lafort 3, but there's also more skull fracture involved in that as well. I'm going to skip over to it actually looks like a child, the third image over. Very large cranial area and very small, delicate looking jaw. But the way that skull is lifted would be considered comminuted. On the far right, that is post-surgical repair of, like I was talking about, a gunshot wound, self-inflicted gunshot wound that basically exploded the jaw down and out. And you can see all those little bone fragments still, you know, would still be inside the meat, essentially, even though they've done the surgical repair of that mandible. And you can see up around the nasal bones, the orbits of the eyes and whatnot. If you look back over to the live image here, you'll see this gentleman got shot in the face, and you can see the progression of his surgeries that he went through. But then in these 3D images, it's substantial. I mean, it's hardly even discernible what that is, and it's just amazing that a human could live through that. But there it is, when the trauma, the bullet, the tree, you're getting ejected out of your vehicle for whatever reason, and whatever you come into contact with doesn't actually crush your cranial vault where your brain is. A lot of people survive these horrific injuries. and it's really quite amazing. So just to read some of this information because it was interesting. Historically, surgeries to repair this type of injury have been done in multiple stages. This was preferred after a TBI, which almost all comminuted skull fractures include a TBI, and generally requires the surgeon to remove damaged bone and perform cranioplasty or restructuring. Right. The idea behind doing these surgeries in stages was to reduce the risk of infection. Um, these that was um, the idea, but recently studies have demonstrated that there is little to no difference in the rates of infection between immediate reconstructive surgery and the traditional staged approach. And it's considered less traumatic to complete the work all at once. If you think about it, it's less dangerous to sedate and perform this massive surgery to this patient. It's less expensive, and it has improved cosmetic and psychological outcomes for the patient. Again, with the comminuted fracture, I found these images very um, educational. They illustrate it's the same case, and so the top figure shows the patient, immediately post injury, and so you're able to see the fractured facial bones. There's hematoma. There's actually air. The pneumocephalus. There's actually air inside the cranial vault, and then down in the bottom figure, you can see the mesh and the little titanium screws and stuff that they use to repair after they evacuated the hematoma and the pneumocephalus. So I found that to be just very interesting and illustrative of what can be done to repair this type of skull fracture in this patient. I appreciate your time. These are my references. Thank you very much for listening to my random babblings about skull fractures this evening. And thank you. Appreciate your time.